Hello, this is Dr. Paul Miller. I'm the director of the Fertility Center of the Carolinas in Greenville, South Carolina, and I'm going to talk to you today about primary amenorrhea. We define primary amenorrhea as the absence of menstrual periods by age 16 for women who have normal secondary sexual characteristics, or by the age of 14 for women who have no secondary sexual characteristics. The causes for primary amenorrhea vary quite a bit, but if you can keep in mind that 50% of the time it's related to chromosomal abnormalities. The other general categories that we look at are hypothalamic dysfunction, which accounts for 20%, Müllerian agenesis, approximately 15%, transverse vaginal septum or imperforate hymen, or what are sometimes called outflow obstruction, 5%, pituitary disease, 5%, and then other factors such as androgen insensitivity, congenital adrenal hyperplasia, polycystic ovary syndrome, another 5%. So let's just take a closer look at several of these areas. Again, gonadal failure is far and away the most common abnormality. The most common karyotype we see in these women is a 45X karyotype, or what is sometimes called Turner syndrome. Turner syndrome individuals typically have a very short stature and have a lack of any secondary sexual characteristics. They have web-necked, high-arch palate, cubitus valgus, shield chest, low hairline on their neck, short fourth metacarpal, and they oftentimes have streak gonads with renal anomalies, cardiovascular abnormalities, in particular coarctation of the aorta, and they're at much higher risk for having autoimmune diseases. Although you would think that these folks would be easy to spot, quite often women can have Turner's mosaicism, where they not all cells have a 45X karyotype. Some will have a typical 45XX, but they still may have problems with primary amenorrhea. The next abnormality that we see that is fairly common is Müllerian agenesis, or what is commonly called Meyer-Rokitansky-Kuster-Hauser syndrome, or just very simply MRKH. This is an abnormality that affects somewhere around 1 in 4,000 individuals, and it involves agenesis or dysgenesis, really, of the upper two-thirds of the vagina. These women have a normal 46XX karyotype and a normal female phenotype, so normal secondary sexual characteristics, but they have a malformed uterus. Most of the time, if you look with laparoscopy, they do have some small, albeit rudimentary, fallopian tubes, and they may even have a small uterus in the midline, but most times it is uncannulated and non-functional. Up to 40% of these women have some type of renal abnormality. So it's important to do some type of ultrasound, CT or IVP, and approximately 12% have skeletal abnormalities. So it's worth doing some type of spinal X-ray to ensure that there are no missed abnormalities. The next special circumstance that we see that's associated with primary amenorrhea is androgen insensitivity syndrome. This is much less common, only about 1 in 20,000 women, and these women have a 46XY karyotype. Very simply, they don't have the normal receptors for testosterone, and so as a result, they don't form normal male external genitalia, although their gonads are testes. Phenotypically, they tend to be tall, taller than their family history would suggest. They have scant pubic and axillary hair. They tend to have normal or even above normal breast development. They have a blind ending vagina and are sometimes difficult to differentiate from Müllerian agenesis. They have normal male levels of testosterone. That's one thing you can check just to be sure. Normal male levels of testosterone. You can also quite often palpate a gonad in the inguinal canal. So these folks are at higher risk for cancer later on. They typically develop gonadoblastomas or dysgerminomas, and up to 20% of these women will develop these tumors. So these are folks that after they go through puberty, we typically do a gonadectomy to lower their risk. Now, moving on then to vaginal disorders. One of the most common things we see is imperforate hymen. And imperforate hymen usually presents with cyclic pelvic pain, with occasional problems with the incomplete rectal emptying with defecation or incomplete bladder emptying. On exam, what we often see is a bulging hymen with kind of a bluish hue. It looks very tense. The key is, if you do suspect that there is an imperfect hymen with menstrual blood behind it, do not needle these in the clinic. Very simply, if you put a needle through that skin into that menstrual blood, it's a perfect culture environment for bacteria, and that can lead to ascending infection and all sorts of terrible things. These are usually treated by simple excision. We usually do a cruciate excision to create 4 flaps, and then those flaps are removed at their edges. The edges are oversewn for hemostasis, and these youngsters usually do extremely well. Other forms of outflow obstruction include a transverse vaginal septum. This is a much trickier situation. These usually form at the junction of the upper third and middle third of the vagina, right where the urogenital sinus would normally meet the Müllerian tubercle. These septae can be extremely thick. They can be centimeters thick. They're really best evaluated with MRI to see if there's any evidence of hematocopos above or mucocopos above. They require very special surgery with a Z-plasty flaps in order to maintain patency, and I would certainly suggest, if you're not well versed in this type of surgery, that you send these folks to a referral center. Other causes of primary infertility include hypothalamic dysfunction. Again, this is one of the more common things that we see. And what it has to do with is the absence or decreased frequency of pulses of GnRH from the hypothalamus. We see this quite often in association with eating disorders, or with in athletes. Women who are thin tend to be especially prone to this. It is an extremely common problem that is usually seen as a type of secondary amenorrhea, but should always be included on the differential for primary amenorrhea. Another etiology for primary amenorrhea that is usually on a secondary amenorrhea list is hyperprolactinemia. Prolactin from the anterior pituitary is normally present in high amounts during pregnancy to promote breast milk production, but it can also be elevated outside of pregnancy from small adenomas within the pituitary gland. Adenomas that are less than 10 millimeters are called microadenomas. Adenomas greater than 10 millimeters are called macroadenomas. these women will present with very low LH and FSH levels, hypoestrogenism, and failed progression through puberty. Thankfully, these adenomas are very responsive to dopamine agonists, most common of which are cabergoline, also known as Dostinex, or bromocriptine, an older drug, but still one that works quite well. Once the hyperprolactinemia is corrected, these youngsters will typically start to make normal levels of gonadotropins, normal estrogen levels, and will progress through puberty quite rapidly.